People have it in their basin like this. Just have it so you're able to grab it right away to use it. So, you know, I just do it that way. And then we have your mixture, because if we have to go around any vessels, that's when you're going to see the tie on the pass, like you guys have been seeing. You know. Now, I typically, I don't know why if this is out of habit, but I usually have mine separate from, you know, the rest of my clamping, and I have it rested up the other way. Because if I already have my tie,
You keep them on the floor like that.
yeah. If I already have my tie, you know, load. I'll actually already have it loaded. You know, I don't know. Yeah, I'll already have it loaded. Whatever. So I know we're having you guys practice that, but if you're going to be one step ahead, then you guys would typically have this already loaded. I always have my marking pen closest to me, because typically that's the first thing after draping that they're going to use, is the marking pen. If there's local, sometimes they actually do local. There are surgeons that will use local for every single case, but not every surgeon does it. And then your knife blade here. You'll have more than likely a tissue, one regular tissue with teeth, and this is when they're superficial, and then once they reach the hernia sac, so the hernia sac is basically encasing the bowel, allowing it to protrude through the muscle layers, and therefore, you know, people that have hernias, they could usually push it down. Do you guys get what I'm saying? It's basically bowel that's gone all the way to the surface of your skin. Hernias, why do we do, you know, a hernia is basically to put back in place, you know, the bowel. That can actually lead to bowel obstruction at times. It could lead to infection, allowing it to be perforated, that sort of thing. Also, it's painful for people as well. So what we're basically doing is we're putting it back into place, and then we're stabilizing and reinforcing the area that it protruded through. So you will have an implant. That implant is called a hernia mesh, or hernia graft is what they'll call it. Most likely they'll call it a mesh because it literally is a mesh. Yep.
It's kind of shaped like a cone, right?
Yeah, you'll have a cone. It depends on what type of hernia. And when we go into chapter 15, that's another thing that you guys will love learning, is all the different types of hernias.
Okay.
There's ones that look like a cone or a flower. There's ones that are straight. There's ones that are circular. There's a ton, because it just depends on what type of hernia, how big the hernia is, that sort of thing.
Will you know that before you go into surgery, what kind of...
You'll know exactly what type of hernia it is. You'll know the preferences of what specific hernia mesh that they like as well.
Okay.
So typically I'll have one tissue with teeth and then two DeBakey's, or two tissues without teeth. DeBakey's, this one's too long, but it's usually going to be the 7-inch one. So,
When you put the hernia sac, right?
yep, because you guys don't want to have the possibility of perforating the bowel, that sort of thing. You'll also see, at first, you'll actually see the Volkmann or Murphy rakes. And then as we go deeper, you know, down, you'll go to the Army, Navy, then the Richardsons. A lot of times, you'll actually have a surgical assistant in these cases. So that's why they'll utilize the handheld retractors as opposed to self-retained retractors. When a specimen that you may have in this case is actually, they'll isolate and figure out the hernia sac, and they'll actually take it out. Hernia sac is kind of like those adhesions that we were talking about. It's unnormal, or it's tissue that